Good evening, everyone. Thank you so much for coming tonight to our Peer Review Live seminar, From Innovation to Implementation, Unlocking the Full Potential for Antibody-Drug Conjugates in Solid Tumors. I'm Sarah Hurvitz. I'm professor of medicine and the head of the Clinical Research Division at the Fred Hutch Cancer Center, University of Washington. Really pleased to be here among a very esteemed panel of colleagues. Stephen Liu, Associate Professor of Medicine and Director of Thoracic Oncology at the Lombardi Comprehensive Cancer Center at Georgetown. Funda Meric-Bernstam, Chair, Department of Investigational Cancer Therapeutics and Medical Director of the Institute of Personalized Cancer Therapy at MD Anderson, and Kathleen Moore, Deputy Director of the Virginia Curley Cade Chair in Developmental Therapeutics and Co-Director of the Cancer Therapeutics Program at the University of Oklahoma. Welcome, all of you. Thank you so much for being here. So thank you to PeerView for providing this session, AstraZeneca, Daiichi Sankyo, and Gilead Sciences for providing educational grants for this symposium. If you already haven't done so, please do complete the pre-event survey. Look out for additional polling during the program. This is an interactive evening, and submit your questions, and we will answer them during the Q&A session at the end. In-room learners, use your mobile phone to scan the QR code shown right there on the following slides to respond to surveys and polls and ask questions. And if you ask questions, there's going to be some people tonight at the end who win Amazon $50 gift cards. You'll know because your phone will start flashing. And so here you go, earn the chance, $50 gift cards, so go ahead and use this QR code. And thank you so much to PeerView for providing these gift cards. Visit us at peerview.com/Chicago25. You can see the slides and practice aids. You can see them now, and you can download them after the event. Our goals for today are shown here. We're going to be augmenting your knowledge on the evidence of current and emerging ADCs across solid tumors, enhance your skills identifying patients with breast, lung, gynecologic, bladder, GI, and other cancers who are candidates for ADC therapy, and equip you with strategies to ensure safe integration of ADCs into treatment plans of patients in real-world practice. And for our first talk, I will now be turning the mic over to Funda to talk about ADC foundations.
Thank you so much. It's really my honor to be here. I'm from MD Anderson Cancer Center, and I've been very interested in ADCs for a while. We're going to talk about structure, mechanism of action, research, and clinical considerations. I'm going to start off with a polling question, so you'll get experience with answering and hopefully win the gift card. I'll read it off so you'll have time to answer the question. Which of the following is inaccurate about ADCs? They enable more precise delivery of cytotoxic agents directly to cancer cells. They leverage the unique binding affinity of antibodies for tumor-associated antigens. They combine the specificity of antibodies with the potency of chemotherapy. They can be engineered to target more than one target or carry more than one payload. They are targeted therapies that lead to no notable side effects, or I'm not sure. If you like the question, thank you. If you didn't like the question, I helped the AI tool to generate the question. Okay, well, great job. And for those that you're not sure, you'll be sure by the end, hopefully. Okay, so I know that many of you know a lot about ADCs, and while some of you maybe were learning about ADCs, so I want to really go over, some of the basics of ADCs. So this is an area of much excitement. Let's start off a little bit about the antigen target. This is a key component for ADCs, of course. The ideal target, it would be highly expressed in tumor. Most ADCs are tumor-targeted, homogeneously expressed, with limited or preferably absent expression in normal tissue, with ability to efficiently internalize. Many of the ADCs are internalized in their activity. Important components of the antibody. We're looking for something with high affinity and avidity, something with a longer half-life, so it'll be easier for our patients. Something where the conjugation won't affect the ADC stability or internalization. And of course, the payload is very, very important. The approved solid tumor ADCs currently have chemotherapeutic payloads. These are highly potent. Currently approved ones have microtubule inhibitors or DNA damage agents. The payload needs to be amenable to linker conjugation and stable in the circulation. With the mechanism of action, hopefully we understand. Some of the newer ADCs have focused on having a bystander effect. We'll talk a little bit more about that later, with the drug-antibody ratio being optimized based on the target in an ADC. The linker, of course, also very important, determinant of the stability in the circulation. You need efficient release of the payload once it's internalized. This could be a non-cleavable or cleavable strategy. And of course, we want to not have premature release that could have systemic toxicity. And there's a lot of effort now looking at whether there could be selective intracellular payload release, especially preferentially in the tumor. We talk about ADCs as if it's a new invention. Really, the idea of ADCs goes back many, many, many years. But really, initially, the delivery and activity we've seen was in hematological tumors. Only in the last several years have we seen success in solid tumors. And as you know, in the last few years, there's been a lot of excitement surrounding ADCs with a lot of drug development in the space. So, where are we now? So we go back to the trastuzumab, the TDM1 strategy for HER2-positive breast cancer, where it was the very first approval for solid tumor. And following TDM1, we saw approval for trastuzumab deruxtecan, again, another HER2-targeted agent that was approved for HER2-positive breast cancer. The first TROP2 targeting ADC approved was sacituzumab govitecan. That was approved initially in triple-negative breast cancer, and then in breast cancer also in hormone receptor-positive space. And then we started seeing additional targets being developed. There was approval of enfortumab vedotin, targeting Nectin-4 in urothelial cancer, initially approved monotherapy, more recently approved in combination with pembrolizumab. We saw approval of a tissue factor ADC for cervical cancer, targeting a folate receptor for ovarian cancer. So this is a really active area of development. And most recent approval was for another TROP2 ADC, datopotamab deruxtecan, in hormone receptor-positive breast cancer. So just a review of the mechanism of action of these ADCs, and then we can talk about sort of what are the differences and what are the things that are coming down the pike for development. One, there may be activity that is associated with the antibody engagement of the target. One aspect, there may be some immune stimulation just of the Fc-mediated stimulation of immune cells. And of course, for some targets like HER2, by disrupting the downstream signaling, there may be target-specific, by inhibition of oncogenic signaling. Most of the ADCs we're talking about have been focused on internalization of the ADC with release of a chemotherapeutic payload. So there, we're talking about cancer cell death, hypothesis that there may be some immunogenic cell death, and maybe, depending on payload, we're learning more about the space. And then, as we discuss, although there may be preferential delivery to the cancer cells that are expressing the target, there's also the idea that you could have the cancer cells close by that may not be expressing as much of the target, still may have cancer cell kill with a bystander effect. So, when we talk about ADC targets, there are several aspects of the ADC target that affect ADC function. Now, this is depending on the function of the antigen shedding, internalization and recycling of the antigen, and the selectivity of expression within tumor cells. So all of this may affect, the ADC activity. And you can see that there's a sort of long list of ADC targets. Most of these are ADC targets that are overexpressed in cancer cells. Some ADC targets also have oncogenic effects, such as HER2. So there may be an additional strategy related to that from a cancer cell kill standpoint. However, there are other ADCs in development not targeting specifically cancer cells per se. There are some target antigens that are expressed in the tumor vasculature, and also others that are now being developed looking at targeting the stroma. So a lot of interesting targets and a lot of new development in ADC space. Currently, as I mentioned, all the approved ADCs are cytotoxic, and there's been really a significant emphasis still on the most recent ADCs that have gone into the clinical trials of either antitubulins or topoisomerase inhibitors. And you can see in green that, in fact, the topoisomerase inhibitor strategy has been especially favored in the last few years. And if we look at the two first approved solid tumor ADCs, the T-DXd and T-DM1 for HER2-positive breast cancer, you can see these ADCs actually have substantial differences. And of course, Sarah in a few minutes will review some of this data. But when we look at these ADCs, they have a difference in their payload. T-DXd carries deruxtecan, which is a very potent topoisomerase 1 inhibitor. This is thought to have more bystander effect compared to DM1, which is an antimicrotubule inhibitor. There's also differences in the fact that T-DXd has a cleavable linker. In addition, these two agents differ in their drug-to-antibody ratio, with T-DM1 having a lower drug-to-antibody ratio compared to T-DXd. So we're still learning for each target what is the best strategy to move forward. So let's take a look at the TROP2 ADCs that have been approved, sacituzumab govitecan, which was the first TROP2 ADC approved, and dotapotamab deruxtecan, which is the most recent TROP2 ADC approved. Sacituzumab govitecan has a DAR of 8. It has a SN38 payload. SN38, as you know, is the active moiety also of irinotecan. And dotapotamab deruxtecan also targets TROP2, but with a different antibody, and has a lower DAR, has a 4 DAR. This has a payload of deruxtecan, same payload of trastuzumab deruxtecan we talked about for the HER2 targeting. Interestingly, although both of these ADCs target TROP2, and they have similar technically payloads from a mechanism standpoint, they have very different adverse event profiles, so highlighting that there's a lot yet we have to learn about ADCs and their activity and how they're processed in the body. So from an ADC standpoint, we'll touch back on the toxicities again in a few minutes, but there's several other areas of really great interest right now. One is the idea of biomarker development. We've seen some ADCs not requiring biomarker selection, and several ADCs initially were approved without selection, while others, such as HER2, initially were requiring selection. And we've seen, for example, approval of T-DXd with a specific IHC cutoff. We've seen the folate receptor ADC approved in ovarian cancer with a specific cutoff. So there's a lot about whether we need to measure expression and how to best measure the expression that we need to learn. We also still don't understand mechanisms of intrinsic resistance, mechanisms of acquired resistance, and these are areas that I think over the next few years we're going to learn a lot. This will also help us with a really critical question about ADC sequencing. If a patient already got an ADC, can we go back in with another ADC? Can we go in with a different target? Can we go in with a different payload? What is the best strategy? Is an alternate? Can we go in with a similar payload with a different combination? And so a lot that we'll be looking at over the next few years. There's a lot of different strategies in ADC development, and as you can see, there's a lot of drug development in the space. Every component that we discussed is under active investigation. Can we find novel targets, different antibodies? Can we target more than one target? 2 targets, 3 targets? Can we mask the antibody, only releasing it in the vicinity of the tumor? What is the best linker strategy? Cleavable, site-specific? And what is the best payload? As I mentioned, there's been emphasis on a couple of strategies. Clearly, we need novel payloads. There's strategies surrounding dual payloads, immune-stimulating payloads, and of course, using radionuclides as a strategy as well. So a lot of this is now in active development, and you can see over the next few days a lot of different studies with next-generation ADCs, but clearly a lot of new work with opportunities in the near future. And if you look at AACR 2025, there's a lot of interesting examples of, for example, the dual payload ADCs that are being featured. In addition, area of really importance is the toxicity. Although we talk about ADCs as if it's targeted and it will only be delivered in the cancer cell, the reality is all of these ADCs indeed have some toxicity. Some of this is really related to the linker stability issue we talked about. A lot of it is driven based on the payload. We see substantial differences, for example, between the microtubule inhibitors and topoisomerase inhibitors. We've seen elevation of LFTs, we've seen significant cytopenia, we see significant neuropathy, we see significant eye toxicity. Some of the ADCs have more prominent pneumonitis and ILD. So these are all very important to know and may affect patient selection and may, in clinical trials, as well as treatment selection for individual patients. And again, some of these are on target, while others are more related to the payload. Ultimately, we think there may be further work that can help us with that dose optimization. Is there a different schedule? Is there a different dose plan that will help optimize efficacy while we minimize the toxicity? And then, further work about, other pharmacogenomic components that can help some of this toxicity prediction. Again, there's a lot of work also in the biomarker space. At AACR this year, we'll be seeing a lot of interesting studies being presented regarding to biomarkers. So thank you for letting me share this, and I'm going to pass the baton over to Sarah.
Thank you so much, Funda. That was great. And there's so much excitement now in this field. As you said, I think the ADC posters are drawing a lot of attention at AACR. So please answer this follow-up polling question. We're going to move on, but go ahead and use your QR code. And thank you for all the questions that have been coming in. We're now going to turn to ADCs in breast cancer, the latest evidence and practicalities of clinical integration. And we'll start with the patient history. We have a 56-year-old woman with metastatic breast cancer to liver, bones, and lungs. She's in clinic for treatment recommendations. 8 years ago, she had an ER/PR positive, HER2 low, stage 3A left breast cancer, received neoadjuvant chemo, surgery, radiation, tamoxifen, and letrozole. 3 years ago, she developed metastases to her lungs, ER-positive, PR-negative, HER2-0. She received first-line treatment with ribociclib fulvestrant, was doing well for 18 months when she experienced progression in the liver. Second-line treatment, everolimus exemestane, and progressed again after 10 months. So we want to ask a question: what would you do next in this patient? She's had 2 lines of endocrine-based therapy for ER-positive metastatic breast cancer. Would you biopsy the lung to reassess whether the tumor is HER2 low, biopsy the lung to assess TROP2 expression level, offer treatment with T-DXd, offer treatment with sacituzumab govitecan, offer treatment with capecitabine, or you're not sure? So everyone, please vote. Okay, we've got some I'm not sure's, and we've got biopsying the lung to assess HER2 or TROP2 level, But we have 20% saying treatment with TDXD, and I think that's quite reasonable. This would be first-line chemo. So pay attention to what I show you now, and then at the end you can re-answer this. And so the other question is, what would you recommend if this patient not only had received ribociclib and everolimus, but also a line of capecitabine chemotherapy? Now, what would you recommend as her next line of treatment? Start Dato-DXd, start sacituzumab, start TDXd, biopsy and reassess HER2. Options 1 to 3 are fine, options 1 to 4 are fine, or I'm not sure. Go ahead and vote. Okay, again, about a quarter not sure. So let's go through the evidence. And I would, I think it's gonna become clear as we go through the data. So let's talk about HER2 targeting ADC therapy in breast cancer. And we'll review the evidence. Right now, on the left upper corner, this is how we used to view HER2 in breast cancer. It was either amplified or non-amplified, because 15% of patients or so had HER2 amplification and were candidates for HER2-targeted therapy. But now we're going into this realm where HER2 low breast cancer, meaning low levels of normal expression of HER2, makes a patient a candidate for HER2-targeted ADC therapy with TDXD. And so now we care just to know if a patient has some level of HER2 expression in the metastatic setting for treatment decision-making. HER2-positive metastatic breast cancer. The Amelia trial, as Funda said earlier, was a study that led to the FDA approval of the first ADC for breast cancer, TDM1. TDM1 outperformed standard of care lapatinib capecitabine with an improved progression-free and overall survival for HER2-positive, high-expressing, overexpressing, highly amplified breast cancer. That was the standard of care for nearly a decade until TDXD came along, a second generation, maybe third generation ADC targeting HER2, tested in the DESTINY-Breast03 study against TDM1 head-to-head in patients who had received prior trastuzumab and taxane and had HER2 amplified disease. The results were pretty extraordinary, showing a substantially improved progression-free survival and an improved overall survival with TDXD compared to TDM1, and thus replacing TDM1 as the standard of care in the second-line setting and beyond. The Destiny-Breast trial was a parallel cohort trial interrogating the activity of TDXD in patients with brain metastases and HER2-positive breast cancer. Now, this was kind of a paradigm-shifting concept, is that a bulky ADC was showing activity in brain metastases that were HER2-positive based on analyses of other trials. So this study was based on that observation from other studies and aimed to really look at the outcome for patients with brain metastases and HER2-positive breast cancer with single-agent TDXD. And this waterfall plot here is of patients' brain mets, the shrinkage of their brain mets. And you can see a substantial percent of patients had an objective response in the brain, over 70%. And this included patients who'd never had surgery or radiation to the brain, untreated brain mets. So this is really interesting. Somehow this bulky antibody-based therapy is actually impacting brain metastases and has led us to think differently about the use of this drug in metastatic breast cancer. The progression-free survival was also 17 months in this study for patients with brain mets. When I was back in 2006 or so, when I was just beginning as a breast cancer specialist, the median survival for somebody with brain mets was about a year or less. So this is pretty incredible. We now have a number of studies looking at TDXD in earlier line settings. The top two, Destiny-Breast09, is a study challenging frontline THP, taxane, trastuzumab, pertuzumab, which is the standard of care today. There was a press release, I think 2 weeks ago now, that TDXD beat the standard of care, and this should be presented, I believe, at the ASCO meeting. I wasn't part of the study, but that's what the rumor mill is saying. So we may have a standard of care change very soon in the first line setting. Demether is going to look at whether we can use induction TDXD followed by maintenance antibody therapy to give patients a break from the chemo side effects that come along with TDXD. The Patina and HER2-CLIMA-05 studies on the bottom are studies looking at using oral therapy as a maintenance strategy after patients have undergone treatment, induction treatment. And the Patina study was presented at the San Antonio meeting 4 months ago with very positive results. We're waiting for the publication of that. Now let's turn to the bulk of breast cancer, which is HER2 low and ultra low. And we know that targeting HER2 with drugs like trastuzumab, pertuzumab, TDM1, lapatinib, neratinib, et cetera, doesn't work in the absence of HER2 amplification until TDXD came along. And as Funda showed you, because of its bystander effect, TDXD has been shown to have activity in HER2 low, which is normal expressing breast cancer for HER2, and even HER2 ultra low, which is an IHC 0, but with a little bit of expression of HER2 on the cell surface. The clinical trials, College of American Pathologists in March of 2025 published an update to the breast cancer biomarker reporting protocol, ensuring that pathologists provide us refined HER2 status scoring and reporting so that we can know if a patient's a candidate for TDXD. Now, on those questions, the case that I presented to you, that patient had an IHC 1 at her original diagnosis. When she was diagnosed with metastatic disease, it was IHC 0. She's a candidate for TDXD based on that original 1+. You don't need to re-biopsy a patient as long as they've ever had any HER2 expression on their tumor. Destiny-Breast04 was a study that showed that TDXD works in HER2 low. This study compared TDXD to single-agent chemotherapy of physician's choice listed there. Patients had to have IHC 1+ or 2+ metastatic breast cancer, and it could be hormone receptor positive or triple negative disease. 90% were hormone receptor positive. PFS was the primary endpoint. As shown here, it was a highly positive study. This was a standing ovation at ASCO when it was presented and immediately practice changing, and overall survival was also significantly improved in this study. These Kaplan-Meier curves are for the triple-negative subgroup. Again, only 10% of the patient population, but the Kaplan-Meier curves and hazard ratios look strikingly similar to the intent to treat and hormone receptor-positive population. So many of us are using TDXD in triple-negative HER2-low breast cancer. Destiny-Breast06 was a study looking at TDXD as the first line of chemo after exhausting endocrine therapy or using endocrine therapy for hormone receptor positive, HER2 low or ultra low breast cancer. Again, the control arm was treatment of physician's choice, single agent chemo. Patients had to have had at least 2 lines of endocrine therapy in the metastatic setting, but no prior chemo. And here are the results. A significant improvement in progression-free survival compared to chemo. As of yet, no change in overall survival. Maybe it will be positive later. So there's a little controversy right now because we don't know whether giving patients a line of, for example, capecitabine, like in our patient case, harms their long-term survival. You could still use TDXD in the second-line setting like was done in the Destiny-Breast04 study. There wasn't crossover built in this study or the other studies, so we don't really know, are we benefiting our patients by starting right up front in the front line after endocrine therapy with TDXD. And I think a lot of the clinicians, we look at the pace of disease, the location, the symptoms, and if we want a fast objective response, TDXD is your agent. But if you have slower progressing disease, you might get away with a line of oral chemo with capecitabine, which is quite well tolerated. Here's the PFS and OS in the HER2 ultra-low, IHC 0 with a little bit of expression. Again, very similar outcomes in terms of hazard ratios and Kaplan-Meier curves, encouraging and leading to the FDA approval of T-DXd, even if the IHC is 0, as long as there's a little HER2 expressed. The Begonia study looked at T-DXd in combination with durvalumab, an immune-based therapy. Not a comparative study, but shows a very nice waterfall plot. So we'll have more studies looking at combination with immune therapy. Destiny Breast 08 is looking at T-DXd in combination with capecitabine on the left, capivasertib, an AKT inhibitor on the right. Again, we're seeing nice anti-tumor activity, objective response rate in excess of 50% for both of these combinations, and the question becomes tolerability. There are a lot of adverse events to be aware of. As drugs have more bystander effect, you do have more chemo side effects. More than 3/4 of patients will experience nausea, so it's important to aggressively prophylax against this. Interstitial lung disease can be life-threatening, and patients need to be monitored. The 5 S's is one way to do that. You screen your patients at baseline. You don't use T-DXd if they've ever had ILD, and you look at their O2 sat. You scan them frequently, every 6 to 12 weeks while they're on T-DXd. You stop therapy if you see ground glass opacities, even if the patient's completely asymptomatic, and you use steroids early. And if a patient's ever symptomatic with ILD, you never resume the T-DXd. Let's look at targeting TROP2 in triple-negative breast cancer. The phase 3 ASCENT study led to the FDA approval of sacituzumab govitecan in triple-negative breast cancer after 2 prior lines of chemo in the metastatic setting. These data were really practice-changing because it showed, compared to single-agent chemo, the progression-free and overall survival was significantly improved with sacituzumab govitecan, again, which has a lot of bystander effect. A newer agent, sac-TMT, or sacituzumab tiromotecan, has been reported out from the phase 3 OptiTROP study, looking at sac-TMT in patients with triple-negative breast cancer after 2 prior lines of therapy. This is the PFS and OS data right here. Significant improvements. This is not yet FDA approved, but may be soon. What about targeting TROP2 in hormone receptor positive metastatic breast cancer? Well, the TROPICS-02 study looked at sacituzumab in hormone receptor positive HER2 negative metastatic disease after endocrine therapy, a CDK4/6 inhibitor, and 2 to 3 prior lines of chemo, and showed an improvement in PFS compared to chemo. Only about 1.5 months, but the overall survival was significantly improved, leading to its FDA approval for HR-positive, HER2-negative metastatic disease. The main side effects with sacituzumab, neutropenia and febrile neutropenia. Patients were using a lot of G-CSF up front or as secondary treatment for patients who develop this, and diarrhea is fairly significant, so having antidiarrheals on hand at home, as well as full body alopecia. I've not seen a patient escape from alopecia. Don't believe the grade, the 46%, it's 100%. That's just underreporting. And so the management of toxicities with sacituzumab requires warning your patients about alopecia, treating for the GI side effects. Early onset diarrhea, we should consider atropine, late onset loperamide. And because we are dosing sacituzumab day 1 and 8 every 21 days, you can't use long-acting G-CSF after day 1. And beware that on day 1, your ANC needs to be 1,500 to start therapy, not 1,000. On day 8, it needs to be 1,000. TROPION-Breast01 is a study looking at datopotamab DXd, a TROP2 targeted therapy in hormone receptor positive breast cancer. Funda showed you the structure of this ADC, and this study was positive, leading to a 2-month improvement in progression-free survival that was statistically significant. The overall survival was not yet improved. The response rates were improved compared to single-agent chemo, but we're waiting on the OS data. in spite of not yet having OS data, this drug was approved just a few months ago for breast cancer that's hormone receptor positive. Again, unique side effects. Again, this is DXD, just like in TDXD, so the payload, but the side effect profile is a little different from TDXD. You have eye disorders like dry eye and keratitis, so patients need to be using eye drops, and you can have mouth sores, stomatitis, and there is the risk of ILD, although it's a lower risk than you see with TDXD. About 40% of patients will have some level of ocular event, and so artificial tears and avoidance of contact lenses is recommended in patients. And for the stomatitis, we're using prophylaxis with steroid mouthwash, as well as sucking on ice chips during the infusion as a way to mitigate that. So we are now shifting the roles of ADCs in breast cancer and moving to earlier treatment settings. We have studies of TDXD and Dato-DXD in the neoadjuvant setting. In the adjuvant setting, all of these agents are being evaluated. And in the metastatic frontline setting, we have data coming out. And as I said, the Destiny Breast 09, the press release indicated it was positive. And we also had a press release for the Ascent 04 study looking at sacituzumab with pembrolizumab, which was positive, so we expect to see that report out at an upcoming conference soon. So let's discuss our case again. This is our 56-year-old woman with metastatic breast cancer. 8 years ago, it was ER positive, PR positive, and HER2 1+. She had curative intent therapy. She had endocrine therapy. She was off her endocrine therapy. She developed METs to the lungs. Biopsy was ER positive, HER2 0. She got first-line treatment with a CDK4/6 inhibitor, second line with everolimus, and now she has shortness of breath and cough and is experiencing disease progression. So as second-line treatment, next-line therapy, so third-line treatment, what should we recommend? In my opinion, I think given the patient is symptomatic with her disease, having shortness of breath, it would be a discussion with the patient regarding the availability of TDXD in the frontline setting, the first line of chemo based on Destiny Breast 06, versus using single-agent chemo like capecitabine, which is better, in my opinion, better tolerated, but probably less active in terms of inducing a response. I think I would go with TDXD here, and I wouldn't put her through another biopsy because we know at one point her disease was HER2 1+. So we're going to move on, but please take a moment to answer 2 follow-up polling questions. Go ahead and get out your phones, scan that QR code, and answer the question. I'll let you all take a picture of that and keep the questions coming in. I know y'all want your $50 gift card, so we're seeing tons of questions come in. And with that, I am going to go on to Dr. Liu.
Thanks, Sarah. So it's a pleasure to be here in such esteemed company. And I think in lung cancer, a little newer to the ADC world, but clearly these drugs are impactful, have and will continue to change the standard of care. Let's again start with a case to sort of frame our discussion. Here's a typical person we might see in the clinic, a 52-year-old male, light smoking history, diagnosed with metastatic lung adenocarcinoma to the lungs, liver, bones. We do our biomarker testing. We don't see an actionable target. Our PD-L1 is low, and so this patient gets carboplatin, pemetrexed, pembrolizumab, frontline chemoimmunotherapy, really our preferred modality. Partial response, but after 7 months, we've got progression. So what do we do in this setting, and how can we do better? Got a polling question as well. Which of these biomarker results, if positive in this case, could lead to prescribing an FDA-approved ADC as next-line therapy? Is it TROP2 IHC of 2+, a HER3 mutation, HER2 IHC 3+, MET amplification, or not sure? Go ahead and scan that QR code and let's key in an answer. Okay, about a quarter not sure. It's okay to be not sure, I think it's okay to be. Wonderful. Let's talk a little bit more about these. So when we think of biomarkers in lung cancer, we have a plethora, fortunately, and HER2 is one of them, as Sarah outlined. This plays a role. Clearly a validated biomarker in breast cancer, plays a role in others as well, such as Gastric cancer plays a role in lung cancer, but dysregulation of HER2 in lung cancer comes in a couple different flavors. We have overexpression, and depending on how you define it, 2 plus, 3 plus, you're looking at maybe 30%. If you really limit it to 3 plus, about 2 to 6%. And HER2 mutations are really our established biomarker as well at 1 to 5%. That's where we saw the early activity. HER2 mutations occur typically clustered around exon 20. There are other activating point mutations that are relevant, but when we get these NGS reports for our patients with lung cancer, it can be a little confusing. Sometimes it's hard to know if this is a true driver or not. We've got a lot of resources. OncoKB listed here can help you tell you what's real. You can call the commercial bioinformatician or your own institution. I think in the slide deck, Dr. Hurwitz's email will be there too. Lots of resources to find out what's relevant and what's not. But for HER2, our official NCCN guidelines would be to test all tumors for HER2. We are well past the tipping point of PCR and single gene tests. We should be doing NGS. We're not testing just for HER2 mutations. We're testing for actionable alterations really at the time of diagnosis. But what really has changed practice has been HER2 protein overexpression. This is a little different. And so now we need IHC, something that I think in the lung cancer diagnosis specifically, we've done a suboptimal job of. Certainly an area that we can improve on. HER2 has been a validated target. We've known about HER2 for a while, but our older HER2 drugs, afatinib, lapatinib, trastuzumab, really minimal activity in lung cancer, whether you use overexpression or mutation. It was really the ADCs where we saw activity. First, some activity with TDM1, but our first and only approved ADC in lung cancer is TDXD. So trastuzumab deruxtecan, this is based on the DESTINY-Lung1 study. This showed us this drug was active in lung cancer. The initial study in previously treated non-small cell lung cancer, 2 different cohorts, one for overexpressing, one for HER2 mutation. And it's really that mutation where we saw the early signal. Here we see a waterfall plot, pretty impressive. Response rates 55%. We see the vast majority of patients with some reduction of tumor. This looks like targeted therapy. And at the bottom, this was across different HER2 mutations and really was independent of HER2 expression. PFS 8 months, survival 18 months. In this previously treated setting, these are impressive numbers. Clearly activity, when we look at toxicity to balance it, even though it is a targeted drug, as was outlined by Sarah, the toxicities align much more to chemotherapy, nausea, vomiting, alopecia, myelosuppression, things that aren't prohibitive to use, but certainly things we got to counsel our patients about, pre-medicate, prophylaxis, and anticipation. Really important here. But when we look at TDXD in DESTINY-Lung1, which started off at a dose of 6.4 mg per kg, we see the rate of pneumonitis, I think, probably a little too high for most of us. All-grade pneumonitis at 26%. A little concerning here in this lung cancer population. When we dug a little deeper, looking at the doses, DESTINY-Lung2 helped us establish what is the right and approved dose. This was a 2-to-1 randomization for HER2 mutant lung cancer, randomized to 5.4 mg per kg every 3 weeks or 6.4 mg per kg. And what we see from an efficacy standpoint, response rate right around 50% for both. If you look at the right, those PFS curves look awful similar to me. Really efficacy similar between the 2 doses. Safety, though, much better at that lower dose. Here we see that tornado plot showing less grade 3 toxicities, and at that ILD rate, less than 6%, 5.9% with 5.4 mg per kg. So if you're being diligent, pulling the New England Journal paper for trastuzumab deruxtecan, that is not the right dose. It's that follow-up JCO paper for DESTINY-Lung2. 5.4 mg per kg every 3 weeks is the right dose for lung cancer. Similar efficacy, much better safety. That's the drug we should be using for patients with lung cancer. As was outlined from DESTINY-Breast12 and DESTINY-Lung2 and 1, we did see patients with measurable brain metastases had a response. This drug does cross the blood-brain barrier. We see CNS efficacy. 86% of patients with measurable brain mets had some reduction. And this is important for HER2 mutant, where we think these driver oncogene lung cancers have a tropism for brain metastases. So very important that they have CNS activity. What about HER2 overexpressing? Well, in DESTINY-Lung1, we had a cohort for HER2 overexpressing. This used IHC 2+ and 3+. Response rates here around 27, 34%, lower than what we saw in mutation. But in a world where docetaxel is our standard, where alone docetaxel gives you a response rate south of 20%, this is clearly meaningful activity. When we look at DESTINY-Lung3, we saw higher response rates, and in IHC 3+, a 56% response rate. Not quite as durable or robust as we see in mutation, but clearly an active drug, and even the combination of docetaxel ramucirumab not showing these numbers. So when we know IHC is present, this is clearly what I would reach for after frontline treatment. The key really is knowing that IHC is positive. And so this is something we have to remember to test for up front. So when we need this information, we have it. The field will continue to change in HER2. Destiny Lung 4 will compare frontline TDXD to chemoimmunotherapy. When we look at TDXD in that HER2 mutant population, which is where this is being studied, it looks like a frontline treatment. Very high response rates, a very favorable therapeutic window, but we will have data in the frontline setting, and I think this will change practice. But right on its heels, we do have some TKIs, BAY2927088, and zongertinib. We'll see some data for zongertinib at the lung plenary tomorrow at 10 o'clock. And so other TKIs, we'll see where these shuffle out, but clearly TDXD, an active drug, an important part of our armamentarium. Now, what about TROP2? TROP2, I think, is going to play a role in lung cancer, but what we've seen in lung cancer is a little more complicated, and I think we're still figuring out how to use these drugs in lung cancer, maybe a little more disappointing than what we've seen in breast cancer. EVOKE-01 compared sacituzumab govitecan, the TROP2 ADC, to docetaxel. We just said docetaxel, kind of a low bar, but we weren't able to clear it in this study. If we look at overall survival, the primary endpoint, this was a negative trial. Now, there is some separation at the one-year survival rate, numerically an improvement in median, but this did not meet statistical significance. And when we look at progression-free survival and response rate, really no difference here. It's an active drug. We're still trying to figure out exactly how to use it. What about datopotamab, approved a few months ago in breast cancer? How do we feel about this drug in lung cancer? Well, compared to docetaxel, datopotamab deruxtecan, this had dual primary endpoints of PFS and overall survival. Now, this was a positive trial. It did meet its PFS endpoint. If we look at the ITT, we see a hazard ratio of 0.75 that was statistically significant. This did improve PFS. We see curves that split pretty quickly, separation that's maintained, and so this was positive for PFS. And what was interesting is we saw a much cleaner signal in non-squamous histology. We still don't exactly know why, but in non-squamous, here we see that hazard ratio 0.63. More impressive outcomes in non-squamous. In squamous, actually looks like an inferior drug to docetaxel. And so in non-squamous, this is where this drug really is going to show promise. Overall survival, well, unfortunately, this did not meet its overall survival endpoint. If we break it down by histology, we do see a trend in non-squamous, again, the opposite in squamous, but this wasn't really powered for OS in the subtype, and so it did not meet its overall survival endpoint. This drug is not being pursued in an all-comer population in this setting. But we see some separation here, and so what we really need for TROP2 is the biomarker. We've seen early on that TROP2 immunohistochemistry didn't hold enough predictive power to be used. It was highly expressed in lung cancer, which is why it's being studied here, but it's not really the right biomarker for this drug. What might be is normalized membrane ratio by quantitative continuous scoring. These data presented at WCLC last year by Dr. Marina Garacino from Chicago, and this looks at internalization by quantitative continuous scoring. So NMR by QCS really looks beyond just expression and tries to capture internalization. It's a different kind of biomarker for lung cancer. It requires a digital image of the slide stained by a TROP2 immunohistochemistry, whole slide imaging uploaded, and using AI, we look at the optical density of TROP2 expression on the cell membrane, but also in the cytoplasm, because it really is internalization. Again, this is unique to this specific mechanism. For a drug with this cleavable linker, we need internalization to release the payload. And so it doesn't matter how much is expressed on the outside. It doesn't matter how much is binding. What we want to know is how much is being internalized. This tries to capture it. And so if I would predict how would this biomarker perform, I might say, well, if you had a positive biomarker here, if you're showing signs of internalization, that should predict datopotamab efficacy, should have no impact on docetaxel. It's exactly what we see. In the biomarker positive, datopotamab clearly superior to docetaxel, tripling the response rate from 10% to 30%. A PFS hazard ratio here is 0.57. In biomarker negative, it's really the same as docetaxel, minimal efficacy. And if we look at it a different way, datopotamab deruxtecan clearly active in that biomarker positive, not showing activity in the negative. Docetaxel doesn't matter. It is agnostic to internalization. It's exactly what we see. Now, this is retrospective, but I think these are the types of biomarkers we need to think about. And it ties down to mechanism. And this will be different for different types of ADCs. But what's going to predict if this drug works is internalization, not just expression. The other area where these drugs are being explored are those with actionable genomic alterations. Now, take EGFR, for example. We have multiple options in that frontline setting targeting EGFR, but once we have progression, their options do fall off, these ADCs are showing activity in datopotamab in both TROPION-Lung05, a single-arm phase 2 study, and TROPION-Lung01. If we look at just the EGFR post-TKI, we're seeing very promising activity. We see a PFS hazard ratio 0.35. We see response rates between 40 and 50%. This is an area where these drugs are showing activity and where it is seeking approval. We've seen similar data with sacituzumab tirumatican, TROP2 ADCs in this EGFR space post-TKI. I think this is going to be a viable option going forward. Other ADCs that we're expecting to see, the Luminosity study, a phase 2 study looking at telisotuzumab vedotin. This is a c-Met antibody-drug conjugate. Was studied in a couple different populations, squamous lung cancer, big unmet needs, EGFR mutant lung cancer, but really not seeing activity there. It's the EGFR wild type non-squamous where we are seeing activity. And if we look overall, the response rate's about 29%, but in that c-Met high, we see response rate 35%, still some activity in c-Met intermediate. And if you look at that waterfall plot, we are seeing some deep responses that can be durable as well. This drug is under review as well for c-Met positive previously treated. What about small cell lung cancer? A lot of needs here where we have chemoimmunotherapy first line. We have T-cell engagers and cytotoxic in the second line setting. What about ADCs? Ifinatamab deruxtecan, that same deruxtecan payload, that same cleavable linker, but here targeting B7H3, protein highly expressed in small cell lung cancer. And when we look here, this was the ID8 study presented at WCLC, that 12 mg per kg dose, we're seeing better responses. Response rate 55%. This is previously treated small cell lung cancer. These are impressive numbers. A disease control rate north of 90%. Impressive activity in a very refractory recalcitrant disease setting, and these were fairly durable. We see the PFS at that 12 mg per kg dose at 5.5. We see the overall survival in the previously treated setting of almost a year. Clearly active drugs, but I think we still need to figure out exactly where do these fit. Frontline, maintenance, refractory, still shaking that out. ABV 706, a different ADC, this targeting SEZ6. We're starting to see some interesting targets that we're trying to leverage in small cell lung cancer. Here we look at a response rate, very high, 61%, deep responses, limited numbers, but we're excited to see multiple ADCs coming out. And the question is, can we sequence these? Can we combine these? What do we know about resistance? And we really are in the nascency of how we use these drugs. So we're back to this case, 52-year-old, light smoking history, had chemoimmunotherapy up front with carboplatin, pemetrexed, pembrolizumab. Do we need to test for additional biomarkers? And really what we're looking for here is that HER2 expression. TROP2-IHC is not our biomarker. HER3 mutations, there's really no kinase for HER3, so that's not relevant either. c-Met, it's not amplification. For MET, it's overexpression, and that drug not yet approved. It's HER2 expression. But the challenge is for clinicians in the audience, when we see someone and they are progressing on chemoimmunotherapy, maybe they're symptomatic, but the clock is ticking, those patients want to be treated today. And if I now order HER2-IHC, we retrieve the tissue from 7 months ago, maybe I have to track it down from a different hospital, maybe it's exhausted, we're losing time. Patients want a treatment there, and so unfortunately we might resort to using docetaxel, saving testing for third line, and there's so much attrition in this disease, it's really something we want to avoid. If we want to take advantage of HER2 overexpression, we need to know up front. Even though it's not approved as a frontline treatment, it has to be part of initial testing, or we're going to forget, and we're not going to have the information when we need it. And so one thing we could do better in lung cancer, we're doing a pretty good job with next-gen sequencing, but we need to start thinking about our protein targets as well. And so HER2 overexpression, really important to test up front for non-small cell lung cancer. So again, we have this follow-up polling question. There's a QR code here. Go ahead and click the answer, and we're going to move on to this, and I'll turn things back to Sarah.
Excellent. Thank you so much, Stephen. We'll give people a little bit of time, take a picture, and submit your answer. Now that you've been basically given the answer, I know you're going to get 100% right. Thank you for all the questions we're seeing. It's going to be quite the competition for those $50 gift cards. All right, everyone's got their cameras down. All right, I think we'll move on to Dr. Moore.
Wonderful. Well, good evening, everyone. I'm Kathleen Moore. It's my absolute pleasure to be here on this panel. I'm very grateful to Dr. Liu, who had finished ahead of time and gave me 4 extra minutes plus my time, because I'm talking about 5 cancers in my little talk. So this is going to be a little bit fast and furious. GI, GYN, and GU, kind of where we are with antibody-drug conjugates. But as with all the other presentations, let's start with a case. And this is a real case that we are seeing right now in the GYN community. I'm a GYN oncologist. It's a 64-year-old woman. She presents to our emergency room with a 6-month history of vaginal bleeding and abdominal pain, gets scanned and biopsy, and ultimately is diagnosed with stage 4 uterine papillary serous cancer with intraperitoneal spread, lots of big lymph nodes and lung metastases. Good performance status, really not a lot of issues, no contraindications to doing your most aggressive thing. And she's had a diagnostic biopsy. She presented with bleeding, so we're able to do that pretty quickly with an endometrial biopsy. And it makes the diagnosis, and our pathologists say, she's likely TP53 mutated. She doesn't have expression on the slides. She's HER2 2+, which we confirm does have amplification with a CEP17 ratio greater than 2, and she's mismatch repair proficient, which we would expect in a serous endometrial cancer. So our frontline standard of care for her could be paclitaxel, carboplatin, or immune therapy, or paclitaxel, carboplatin, trastuzumab. And so that's what she received for 6 cycles with a complete response, and then was on trastuzumab maintenance for 18 months, but now has recurred with measurable lymphadenopathy. And so we'll keep this case in mind as we come back. But it's a pretty simple polling question. This is our second-line metastatic therapy. What are you going to pick for this patient? Are you going to pick lenvatinib and pembrolizumab, for which we have phase 3 data and FDA approval? Or are you going to pick TDXD, for which we have Dr. Meric-Bernstam to thank for Destiny Pan-Tumor and an FDA tissue agnostic approval for 3+. Or you're not sure, which is fine too. So go ahead and vote. Okay, interesting. We'll come back to this at the end, yeah. Oops. So we're going to start with GYN tumors. And you've already seen this figure. This is an amazing review article. If you take nothing from my talk, this is an amazing review article you should all pull down. But it does show, we have probably, this is from 6 months ago, there's probably 200 antibody-drug conjugates in development across hematologic and solid tumors. And one of the big places, and you're going to see it at this meeting, is the need to diversify both targets and payloads. Right now in GYN, we basically have 2 payloads, and I think this is probably true for all solid tumors. We have microtubule toxins, which were the original kind of TDM1, and I'm going to talk to you about mirvetuximab. Kind of the bulk of antibody-drug conjugates that were developed were focused on microtubule toxins, and really now it's a camptothecin world, and that's very true in GYN. We are developing in both spaces, though, and the reason I bring that up, and you've heard reference to this throughout these talks, and I think even in breast cancer, where they have 3 approved medicines and have been around long enough that they're doing studies in sequencing, we're all behind that, especially in GYN, and we're wondering about sequencing of these agents, and does it matter if I have a microtubule toxin followed by a camptothecin or the reverse? What are the mechanisms of resistance? And so my assumption here, and this is a big assumption I am making, and it's just for the point of argument, that I think in GYN our patients are probably going to get 1 antibody-drug conjugate that's a microtubule toxin and 1 antibody-drug conjugate that is a camptothecin until we have more diversity of payloads. But I may be wrong with that, so I'm just going to make that assumption for argument's sake right now. And I'm going to start, for GYN, I'm going to kind of group things a little bit just to get through it. I'm going to start with folate as our target, because in GYN, especially in ovarian cancer, we've been focused on trying to exploit the fact that 80% of high-grade serous ovarian cancer has some folate expression, and then there's a variety or variation in the degree, but we've known this for a long time. It's minimally expressed on normal tissues, and it internalizes. And so we knew, and we've known for over a decade, that it's a great target. It is hard to score, though, and so I can't get too much into the pathology. It gives me a little PTSD, because we did have a failed phase 3 because we messed up the pathology, but we have it right now. But this is just, you can see on the slide, this is the scoring based on mirvetuximab approval. It may change with additional agents, but low expression is a cell that has 20 to 49% of cells with greater than 2+ intensity. So the scoring is based not only on the percentage of positive cells, cell surface, but also the staining intensity. Medium is 50 to 74%, and then high is greater than 75% or greater cells with 2+ or greater intensity. And when you look at high-grade serous ovarian cancer, this figure got shifted a little bit, I apologize, but I think you can tell that about 36% of high-grade serous, up to 40 kind of globally, will have high expression, that's 75% or greater. And then about 60-ish%, 64% will have medium and high. And then the rest have low to 0. It sounds like a HER2 scoring again. But this is the population. This is high-grade serous. We're looking at it now in the other epithelial ovarian cancer as well. So I mentioned mirvetuximab soravtansine. This is the first antibody-drug conjugate approved in ovarian cancer. This was presented in 2023 by me, so I'm biased. Just so you know my conflict, I'm biased. But this is the first one approved. It is the first medication ever in the history of ovarian cancer to show both PFS and overall survival advantage, and really sort of threw the gauntlet down for us in drug development that we can do this in ovarian cancer. We can improve overall survival, and it just shouldn't be based on PFS alone. Mirasol was the name of the study and demonstrated that. You can see on the top a 35% reduction in the hazard of progression, and then on the bottom a 33% reduction in the hazard of death, with the use of mirvetuximab as compared to investigator's choice chemotherapy. Mirvetuximab targets folate, that's obvious, but it has a DM4 payload, so this is a microtubule toxin. It also improved overall response rate, and I think you heard someone mention this earlier. Response is really important in platinum-resistant ovarian cancer. Often our patients are very symptomatic, and we need something to work quickly. We need that ascites to dry up. We need them to be able to eat again. And so a 42% response rate versus a 16% response rate certainly shouldn't get you an FDA approval, but clinically it's very meaningful in terms of helping patients feel better while we're helping them hopefully live longer, and that's the point of all this drug development that we do. And so this is exciting and opened the door for ADCs in development, not only in ovarian but in gyne. This is a limited list of all the folate ADCs that are in development. I don't have enough time to take you through them all, but I'm going to show you one, which is rinatibart sesatecan. We call it RINA-S. This also targets folate receptor alpha, but it has an exatecan payload. Sorry, exatecan payloads. This is a camptothecin. So it's not just another mirvetuximab. This is a completely different medication. This data was presented and updated by Dr. Elizabeth Lee from Dana-Farber, and you can see the two doses. They are dose optimizing between 100 and 120 milligrams per meter squared. This is given every 21 days. And you can see at the top, I know the slide is small, but there's a big differential in the efficacy between these two doses. With 120, we're seeing response rates north of 50%. Small numbers, and enrollment is ongoing, but this is a big signal. But also, as you heard about today, these aren't the magic bullets, and we do see off-tumor, off-target toxicity. In this case, not surprising for camptothecins, it's hematologic toxicity. So that's the therapeutic window. With this particular agent, it's very effective thus far, but we have to balance the toxicity, which is primarily hematologic. This isn't a big phase 3 clinical trial now at what they think is a recommended phase 2 dose of 120 milligrams. Irrespective, you don't have to be folate high, you just have to have some folate expression, so it's wide eligibility. 80% of high-grade serous have this. Platinum-resistant, RINA-S versus investigator's choice chemotherapy. If a patient has a folate receptor alpha high tumor, they have to have received mirvetuximab before they can come on this clinical trial, because it is not included in the control arm. So this is enrolling currently. We've talked a lot about HER2 today, so I do not have to go over the structure, but in GYN, we've known about HER2 for a long time in endometrial cancer, particularly serous endometrial cancer. We've been testing for this because, as my case demonstrated, in HER2 3+ or HER2 FISH positive, an option is paclitaxel carboplatin with trastuzumab, and then the option to have a maintenance therapy in a setting where previous to our recent approvals of immune checkpoint inhibitors in this space, we didn't have an option for maintenance therapy. So we've been testing serous tumors for a long time. We were not testing anyone else systematically. So this is very new to us, and we are catching up and really trying to figure out what the percentages are that are 3+, 2+, and 1+, and really how we should even be scoring. We use gastric scoring based on Destiny Pan tumor, but for trastuzumab alone, we use breast scoring. And that gets quite confusing for our pathologists that we're using 2 different markers. So we're really at the beginning of our journey with this important agent, but I'm showing you here the endometrial, cervical, and ovarian cancer cohorts from Destiny Pan tumor, all 40 patients each. The top row of each of those boxes shows you the response rate in these recurrent, usually heavily pretreated populations, and these are remarkable response rates. Just to put it in perspective, let's look at cervical cancer in the middle. Once a patient has had paclitaxel, carboplatin, and an immune checkpoint inhibitor, the next line of therapy is tisotumab vedotin, which is FDA approved based on PFS and OS advantage. This is an ADC that targets tissue factor with a vedotin payload. We're grateful for that medication. The response rate's 18%, and the overall survival is 12 months. This cervical cancer, it's 40 patients. We need more information, but we're sitting at a 50% response rate for 2+ and 3+. I mean, I don't care if you come down to 30% with that. I'm still real excited. And I'm testing every patient with cervical cancer for HER2 now, and you can bet every GYN oncologist in the country is doing so. This could be transformative for our patients, and so we very much want to understand, is this a recurrent opportunity or do we move it up? Really a lot for us to learn, but we should be testing routinely for this, especially once we're in the advanced recurrent setting. These results are very thought-provoking early, but we're excited. So that's all I'm going to say about HER2. I know you've heard a lot about it. I'm going to talk about some other things. Cadherin-6 is a new target. Those of you that do GU may have used this in clinical trials. Cadherin-6 is highly expressed in renal cell cancer and, again, high-grade serous ovarian cancer. We don't even yet have to test for it. It's basically going to be there. Now, it's there at different levels, which may or may not be important. We're still discerning that. But raludotatug deruxtecan, or RDXD, has been developed, a deruxtecan payload, so clearly a camptothecin payload. This is data presented a few years ago, also by me, but I'm not leading the phase 3. That was the phase 1 dose expansion. Erica Hamilton and I have worked on this together, demonstrating these are very heavily pretreated patients, a response rate close to 50%. And I'm excited about that. But what I was really excited about is the fact that the duration of response was just under a year. So that's really what you want to see. I don't want to see just a response rate that comes and goes. A response rate that's meaningful and really prolongs someone's progression-free survival and hopefully overall survival is what we want to see as clinicians. And so this was a nice early signal. It has moved into a registration-enabling study. This is led by Deborah Richardson, who's my partner in Oklahoma, and Isabelle Récoucard from Gyneco in France. And this is I'm really proud of them because this is a study that's really not trying to cut corners. The phase 2 is done. You should see results from this in a meeting coming maybe this year, where they really took the time to dose optimize across 3 doses. What's the right dose? What gets us efficacy and avoids the pneumonitis? Because we do see pneumonitis with this medication, very similar to TDXD. How much of this drug do I need to be effective? And do I need a biomarker? All of these patients, thank you to them, had archival tissue and a pretreatment biopsy to really discern whether or not the level of cadherin-6 is predictive and should be used and should be developed as a companion diagnostic, or is this an all-comer opportunity? That information will finalize the design of the phase 3 that you can see here, and that will plan to launch in the nearer future. So stay tuned for this, but this is what we need to be doing to optimize patient safety and benefit. This is a very patient-centric study, but it took them longer to do, which is risky. So I just wanted to call that out. Those were all camptothecin payloads. I told you about mirvetuximab, which is a microtubule toxin, but it's only really available and FDA approved for the high population, which is maybe 35 to 40%. What about the rest of ovarian cancer? Well, we have this target, Claudin-6. Claudin-6 is one of these targets that's probably the closest thing we have to a pure tumor marker. It's not on normal tissue. That's what I'm showing you here. It's only on tumor. And so it's a lineage marker, which may help us with toxicity. TORL-123 is an antibody-drug conjugate targeting Claudin-6 with an MMAE payload, so another microtubule toxin. And this is data presented by Gottfried Konecki. They're selecting for Claudin positivity. I'm going to show you in a figure in a minute what that looks like. But in Claudin-6 positive tumors, the response rate is 50%. This is small numbers still. These are all like phase 1 expansions, and so we're going to have to see what this looks like with more patients. But this is exciting to have another microtubule toxin conjugated payload, antibody-drug conjugate for patients, in addition to the camptothecins, to continue to grow unique agents that may be efficacious for patients with recurrent disease. You've heard a lot about TROP2, so I'm not going to belabor the different agents. You've heard a lot about SG, sacituzumab, trumatican, and datopotamab. We don't have no phase 3 data in GYN as of yet. All of this data was presented mainly at ESMO in 2024. We saw a little bit of SG at a preceding meeting, very small sample sizes, all done in China, which isn't to say I doubt the results. It's just to say I want to see the results in a more heterogeneous population. But in the red box, you can see the response rates in endometrial cancer, EC, ovarian cancer, OC, and cervical cancer. And again, I want to point out the cervical cancer population. These are very small numbers, but again, 50% response rates, and these were not selected by TROP2. So I have TDXD and a HER2 2+, 3+, and maybe I have as good an option for everybody else. That's an exciting opportunity for a population who desperately needs active medications. The data in endometrial and ovarian cancer is also quite compelling, enough to move into phase 3 studies. These are ongoing trials. This is endometrial cancer. Both sacituzumab govitecan and sacituzumab tirumatican have almost identical phase 3 studies in the second-line metastatic endometrial space up against what is a pretty dismal standard of care for our patients of doxorubicin or weekly paclitaxel. Just to put it in context, the expected response rate for those standard of care drugs is 15%, with a median PFS of 3.4 months. Our patients deserve much better, and we're very hopeful that one or both of these will bring a new agent into the space for patients. So stay tuned, these are accruing well. And I mentioned cervical cancer. We had those 2 studies with small patients. This has moved into another phase 3 study that's open accruing. This is TroFuse 20 in second-line or third-line metastatic cervical cancer. SAC-TMT versus physician's choice chemotherapy, including tisotumab vedotin. So they're not making us come post-TV. They're going right up against it. So they're not gaming the system here with an inferior control arm. So I really like this for patients, and I want this to accrue so we can know if this is an agent for our patients. And then B7H4 was just presented in endometrial cancer. It's not really an ovarian or cervical marker. It's really for endometrial cancer. And we saw data with puxitotog, samratican, it's hard to say. In the recurrent endometrial space, this was presented by Stephanie Guyard. And you can see response rates are in the 30+% range. And so this is another promising target that will need validation. And so what does that mean for us? If we have HER2 and folate, what do we do with that? When I'm sending my panel and I get both of these back, we don't really know the overlap of these targets yet. We think that 17% of high-grade serous are HER2 2+ or 3+, and the overlap with folate receptor alpha high is about 12%. And so the HER2 is in blue, in yellow is folate receptor alpha high. And so the overlap could be here, where the other part overlaps with no folate expression, or the overlap could be here, where I overlap a little bit with high and a little bit with medium. And so how do I sequence these I'm probably going to use both mirvetuximab and trastuzumab deruxtecan, but how do I sequence these? And if Renatibart with a camptothecin payload comes around in all folate, and I have HER2 positivity as well, 2 camptothecin payloads, which one do I pick for that patient? How do I know it's the best drug for that patient at that time? And we don't yet, but these are the challenges we're going to face. And then just coming back to the microtubule toxin question, we don't know IHC yet, but we know mRNA largely doesn't overlap between Claudin-6, which is in blue again. Sorry, I'm not that good with colors changing. So Claudin-6 here is blue, and yellow is folate high. So there's a little bit of overlap, but these are largely, at least by mRNA, not overlapping. So it may be that we have a microtubule toxin for all comers. Time will tell. And then how we sequence these into the general scheme of ovarian cancer remains to be seen. So the other thing to think about with ovarian cancer is I'm just talking about immunohistochemistry, but that's not the only thing. There's also BRCA, and there's also homologous recombination deficiency. And if I'm going to move these up into frontline, how do I take all of that into consideration? This is data from Korea. It needs to be repeated in the United States. And it countered what I thought. What I thought is that you would find HER2 expression only in homologous recombination proficient, like those poor prognostic tumors, because it's a poor prognostic marker. And then HRD and BRCA wouldn't have any. But this study actually shows it's mostly in BRCA and HRD, at least in Korea. And so without knowing the context, we really can't pick where we're going to put these. And so this is a study that's open now that I'm really proud of, but I do wonder if it's in the right population. It's in frontline. HRD test negative, chemo bevacizumab, one arm gets bevacizumab, and one arm gets bevacizumab, trastuzumab deruxtecan in ovarian cancer with any HER2 expression, and there's a lot of statistical controls around 1+, 2+, 3+. And so did we pick the right population for this trial or not, I think remains to be seen. And so that is the GYN space. So I'm going to move on to bladder and GI, which are shorter. So there you go. So bladder, I don't know how many of you were at ESMO when Dr. Powles presented this. It's one of those moments where you're like happy to be in the room and just feel people respond to something that's transforming the life of patients in such a physical way. This was one of those kind of moments where you're like, oh my gosh, the world has changed for patients with metastatic bladder cancer. This is the standard of care unless there are absolute contraindications. And so now we have enfortumab vedotin plus pembro, in this frontline metastatic setting, with a lot of effort going into now the mitigation and prevention of the hyperglycemia, the rash, and the neuropathy. And so that's just education to make sure we keep patients centered and safe. But what comes next? Dr. Powles himself, I've listened to him, I always listen to him. He cautions us not to use cure here. And so there is an expectation that these patients will need additional therapy, and there are many things in bladder cancer, but where do ADCs fit in? And the truth is right now we just don't know quite yet, but we do have data from Destiny Pan-Tumor I'm showing you here, where there does appear to be a strong signal for efficacy. You can see in the bottom left, in the all-comer local 2+, 3+, it's a 39% response rate. For 3+, it's 56%, 35% for 2+. So there really does seem to be a gradation between 3+ and 2+, and sort of where this fits into the treatment paradigm in metastatic recurrent bladder cancer remains to be seen. TROP2s have been of interest in this space for a long time. We've seen data here. This is Dato-DXd in pretreated metastatic urothelial cancer, with a tumor burden reduction of 82%. Response rates were a little bit less, but patients benefited in this small study. And of course, the original study, TROPHY-U-01, led to the original accelerated approval of sacituzumab govitecan. And this is a waterfall plot we all love to see. And we hoped that it would be confirmed in TROPiCS-04, but surprisingly it was not. And so last year, just late last year, the accelerated approval that we originally had for SG in this space was withdrawn. So I think the role for TROP2 ADCs, just like HER2 ADCs, remains to be seen in urothelial cancer. I'm going to end with colorectal cancer just to show you briefly Gastric, I'm going to do gastric, colorectal, and then just end on biliary tract. I think this is really where there's a lot of work still to be done. This is early days of how we use these medications. This is gastric. We probably have the most confidence, right? There's gastric scoring. So we have the most confidence here. With Destiny Gastric 01 and 02, this is metastatic recurrent gastric cancer. You can see these waterfall plots, again, are just phenomenal as a clinician, what you want to see, kind of celebrate when you find a HER2 positive gastric cancer because you have such an effective therapy for them. You will see it's now in public domain. The results of Destiny Gastric 04 at ASCO will be a late-breaking abstract. I just looked that up. So that's exciting. We do know that be a press release that the interim analysis showed such a significant overall survival improvement that it's going to be unblinded and you're going to see the data. And then Destiny Gastric 05 is enrolling. We've had a press release that they've enrolled their first patients, is seeking to move this up into combination into frontline. So this is really where we have the most data in GI cancers. Colorectal is a little bit tougher. Colorectal cancer, we have Destiny CRC 01 with nice response rates. This is 3+ and 2+-ish. So in GYN, we just don't care if there's ish or not. Like we're like 2+, we're going to use it. Colorectal, it's been real finicky around 3+ and 2+-ish, and really the benefits in 3+. I had to talk to my GI specialist to make sure I understood that. And you can see that here, the lighter blue are the 2+. The majority of patients are dark blue, which are the 3+. And you can see it broken out here as well with the efficacy, PFS and OS in these single-arm studies. This has not gone into a big phase 3 yet. So where this fits in really comes down to the prior treatment of the patient. Have they had both FOLFOX and FOLFIRI, or did they get FOLFIRINOX? Are they really healthy? Are they going to get tucatinib, trastuzumab first and then this? Or are they just going to bump this up? This is the nuances of being a GI oncology specialist, which I am not. But I think this is why this is getting hard. Is it left-sided or right-sided? Do they have RAS? There's so much that plays into this contextually that I don't think we can say where this fits right now. But it does fit somewhere because the response rates are quite high, as you can see here, 37.8% in a population of patients, again, I think we can all agree needs effective therapies. And I would just call your attention in the subgroups to the 2+-ish, which really don't benefit. And finally, just bringing up biliary tract cancer. This is, again, Funda's data, which demonstrated the extraordinary benefit in these difficult-to-treat tumors with 56% response rate in 3+ biliary tract. Wow. And so this has moved into a phase 3 study with TDXD versus a standard of care Gemcis Durva versus TDXD plus the bispecific PD-1 TIGIT. And this is ongoing 620-patient study that hopefully will be registrational enabling. And so at the end, I know I'm over, I'm sorry, I did my best to get through all these tumors. For this patient, just to come back, she's endometrial cancer, she's HER2 3+, she's had trastuzumab, and now she's recurred. And the questions that I think about, because we don't really know in GYN the spatial and temporal heterogeneity of HER2, although we treat it much like Dr. Hurvitz said, if I find any HER2, it's like a chart biopsy. If I can find anything, I'm going to use it. Because we have access to it. But do I really need, if I have 2 good things, do I need to biopsy again? Are there any other tests I should order? Probably next-gen sequencing. And then what are the other treatment options? And it's really Len-Pem in this setting versus TDXD. And we can see what you think of that in the final question. Thank you very much.
Well, that was a whirlwind and a daunting task, all those tumor types, and you did a beautiful job. So thank you so much. We have a few minutes. We're going to get you out of here on time in 8 minutes. But we did get so many questions, and so I'm going to start by asking a few of them. And I'm going to start, I'll give you a break. First, Kathleen, because you've been working hard over there. So I'll start with you, Dr. Liu. Can you talk about the mechanism of action, maybe of TDXD in the brain? We got several questions about that. I know we don't have really clear answers on this, but what do you think is going on? Can you talk a little bit, since lung cancer is another cancer that tends to go to the brain?
Yeah, I think that we're still kind of learning. I think that a priori probably didn't expect these drugs to work. We're always taught that large molecules like monoclonals aren't able to pass through the blood-brain barrier, but I think it's evolving a little bit. One, is that blood-brain barrier intact in the setting of brain metastases? And there's some emerging evidence to suggest that may not be the case. But we also don't know if the molecule itself is traversing the blood-brain barrier or if it is the payload that is sort of being shuttled through. So I think there's still a lot of possibilities. We know it works. We know it can work. And I think it's a setting where if someone has asymptomatic brain mets, if they're in a safe location, very comfortable using TDXD in the absence of radiation. If they were symptomatic, large, concerning, maybe a different story. But we borrow a lot from breast cancer, so I'm certainly interested in your opinions as well.
Absolutely. Funda, question came in, a couple about ILD, and wanting to understand, first of all, how often are we seeing it in clinical practice with implementation of the 5 S's, and whether or not you can, you're using steroids for grade 1, and if you see mild grade 2 that resolves, are you ever restarting it?
Yeah, thanks so much. I think it's really important to note these ADCs are very different from each other, even if they have the same target. So there's definitely very big differences in the ILD rates. And also note that all the data we showed were based on clinical trials where this was recognized early and was an exclusion criteria. So none of these trials actually enrolled patients that had any baseline significant pulmonary compromise. I would argue that the patient we talked about today with the shortness of breath wouldn't probably been trial eligible because of the shortness of breath. So in clinical trials, initially for TDXD, for example, every 6 weeks there's planned scans. So, and this is one of those things that's really not intuitive. If your patient's asymptomatic, and Sarah mentioned this, but you see changes in the pulmonary fields consistent with beginning of ILD, you have to hold and do a workup. And I can tell you that I've had discussions with my colleagues who intuitively say, well, the patient's fine, we should be able to continue. But in fact, that's where you can get into trouble. So that is a scenario where we're very aggressive, and we have close collaborators in pulmonology where we really pick up the phone and get guidance. This is a scenario where you can do a workup, start with other options. This is a time where other viral sources could need to be ruled out. A pulmonary consultation with a consideration of bronchoalveolar lavage, early reassessment with high resolution CT to see if it's cleared, but early consideration of steroid use for ILD that is grade 1. Based on wording in the clinical trials, steroid use was not triggering that to be a grade 2. If the patient's symptomatic, by definition, that's a grade 2 event, and even if that now resolves, none of our clinical trials have allowed for re-challenge. I've talked about this in the context of TDXD, but there are several other ADCs, of course, that have had ILD. Several of the direct scan ADCs, this has been closely monitored. It does differ based on the ADC. For example, we're seeing a lot less of the ILD with the datopotamab. So it is something that we need to remember. And, for example, same target, TRP2, we see a lot less of this when we look at SG. So important to know the side effect profile of the ADC you're giving.
Thank you. That was great. Kathleen, are you ready?
I'm ready.
You caught your breath. Okay, so we're getting a lot of questions about mechanisms of resistance, and a lot of data, a lot of studies are ongoing looking at mechanisms of resistance. But in the clinic, how are you sequencing ADCs, and what do you think we should be doing? You went through a number of tumor types, and what does your gut tell you about how to select when and if we can sequence?
I think that we're very much paying attention to what's happening in the breast world, and there's actually ongoing prospective studies now. TRADE-DX is one of them. So we're paying very close attention to what you're doing. We have mirvetuximab right now. In places where we have clinical trials, like at my center, the Renatibart clinical trial required prior MIRV, so they have a whole cohort. It hasn't reported out yet, but we'll actually get some data on folate after folate, but with 2 different payloads to see how Renatibart looks with or without prior MIRV, kind of what happened in breast with the enfortumab vedotin with or without prior SG, that kind of look. So I think we're going to be doing those same sorts of studies right out of the gates, trying to get ahead of it a little bit. We've also learned from the breast literature, the mechanisms of resistance doing those on-treatment biopsies often reveals such complex mechanisms all within one patient. It's not just the antigen, it's not just the payload, it's three things, at least what we've seen thus far. So I feel like this idea that we're going to, because I want to do biopsies and learn, I feel like we're going to not understand what's going on. And we're going to have to just figure it out clinically with better studies that track subsequent lines of therapy in a way that we've never done on trials before, to really try and suss out whether or not we should be doing ADC after ADC, or, at San Antonio Breast, Dr. Tarantino talked about the sandwich. Should we be sticking something in the middle like capecitabine and then coming in with something else? We don't use capecitabine, but we just don't know. But I feel like the next generation of trials needs to be really thoughtful about trying to figure this out, because otherwise we're just going to be guessing, and our patients deserve better than that.
Yeah, absolutely. For our last, we've got so many questions. I don't know if your phones are going off, if we have winners in the audience, but hopefully we do, because we got some great questions. But just to close out the night, I'm going to ask each of you to tell me something that you think is an area of unmet need with ADCs, or something you're super excited about in the next year with ADCs. You've all given some really great high-level information about exciting things coming, but pick one of those, either an unmet need or really exciting something that's coming soon. So we'll start with you, Funda.
I think we need more payloads.
More payloads. Okay, very good.
I'm excited about the use of ADCs in the frontline space. And when we think of the combinations that we're studying now, in combinations with immunotherapy, the question is, will they be additive, or will they truly be synergistic? Are we disrupting the architecture in a way that facilitates immune-mediated anti-tumor responses? I think there's a lot of promise there, and I'm excited to see those.
Excellent. And last but not least, Kathleen.
I think for us, the highest unmet need is really understanding of the panoply of camptothecins, like how to pick which one, because most of them are not being designed with that kind of selection in mind, and really understanding if we can, in high expressors, move more of our patients to cure in the front line, like we did with PARP in a few. Like, can we use these in that way is what I'm really interested in, and so we'll see.
Excellent. Well, I'd like to thank all three of you. Absolutely phenomenal job. Thank you to our audience for staying late, and have a great night.